Hello, everyone. Welcome to our Zoom meeting. Today we have different topics, and Dr. Omar and his team will be presenting. So when you are ready, Dr. Omar, please go ahead.
Hello, good evening, good afternoon, everyone. Good evening if you're out of the US. It's a pleasure to be with you today. So I'll be moderating today's meeting, and so let's just jump right into it. So our first topic today is stroke and cerebrovascular diseases. This topic is going to be presented by Dr. Rahma Bara and Dr. Lojain Abdelfadeel. So whenever you guys are ready, just let us know, and Dr. Nader will give you the meetings. Oh, yep, that's it. All right, go ahead.
Assalamu alaikum. I hope everyone is doing okay. My name is Rahma Bara. I'm going to be presenting stroke and cerebrovascular disease with Dr. Lojain. So I'll start. First of all, the objective of this presentation. At the end of this presentation, we hope that we will be able to understand the impact of the cerebrovascular disease on older adults, treatment of acute ischemic stroke, how to recognize a transient ischemic attack, and prevention of ischemic stroke, prevention and treatment of hemorrhagic stroke. The topic covered are impact of cerebrovascular disease, ischemic stroke, and its different type, as well as the prevention of primary and secondary ischemic stroke. Also, we're going to discuss also we are going to discuss hemorrhagic stroke and its type. So first of all, the impact of cerebrovascular disease. The incidence of stroke increases with advancing age, approximately doubles each decade. So stroke is the leading cause of disability and death among older adults. 6 months after a stroke, in those more than 65-year-old, 26% are dependent in activity of daily living, and 46% have miserable cognitive deficits. Fatality rate within 1 month of an acute stroke is 20 to 30% across all age groups. Also, common medical cause of death associated with stroke are myocardial infarction, arrhythmia, heart failure, aspiration pneumonia, and pulmonary embolism. So now we jump to ischemic stroke. So ischemic stroke is caused by occlusions of cerebral blood vessels. Account for approximately 80 to 85% of strokes. Knowing the cause help guide treatment and prognosis. About 27% are due to cardiac emboli. About 19% are due to large vessel disease. About 17% are due to small vessel disease. And finally, about 30% cannot be classified. Small vessel disease causes occlusion of small penetrating vessels due to lipohyalinosis, the meaning is lipid deposition and hyalinization, or local arteriosclerosis. Causes ischemic stroke that are typically less than 1 centimeter termed lacunar infarct. Risk factor for small vessel disease are hypertension, diabetes, and smoking. Lacunar strokes can occur concurrently with other mechanisms of ischemic stroke. The second type is large vessel disease. Large vessel disease, most commonly caused by atherosclerosis, can cause progressive occlusion of cerebral vessels in the anterior and the posterior circulation. It can be identified by non-invasive imaging of the carotid arteries, like Doppler ultrasonography, computer tomography, angiography, or MRI angiography, or conventional angiography. Risk factors include hypertension, hyperlipidemia, diabetes, and smoking. The third type is cardioembolic stroke. Cardioembolism is an important, potentially preventable cause of ischemic stroke. Atrial fibrillation is the most common cause, associated with 4 to 5-fold increased risk because of thrombus formation in the left atrial appendage and cardioembolism to cerebral vessels. Cardioembolic stroke due to atrial fibrillation account for 25 to 30% of all ischemic strokes. Cardioembolic stroke often occurs without preceding transient ischemic attack. The fourth type is cryptogenic stroke. Cryptogenic stroke are ischemic stroke that does not have a clearly identifiable cause. Use brain and vascular imaging to assess the size of the vessel involved. Also, we consider a typical cause of stroke such as vasculitis, coagulopathy, mitochondrial disorder. As well as prolonged cardiac monitoring is sometimes needed to capture intermittent atrial fibrillation as a potential cause of cryptogenic stroke. Now, the immediate treatment of acute ischemic stroke. Sorry. Quickly, we use a head CT imaging to determine whether the patient is suffering from an ischemic or hemorrhagic event. We assess the severity and the pattern of neurologic deficit, such as by using National Institute Health Stroke Scale, and identify non-stroke cause of acute neurologic dysfunction, such as migraine, seizure, and drug intoxication. So we use National Institute of Health Stroke Scale. So this scale, show us how much there is an impairment. So the greater score reflects an increase of impairment. We can find it at this link. Acute care of the older stroke patients. First of all, we have to optimize hydration status gradually to prevent cerebral edema, control blood pressure while avoiding hypotension, prevent deep vein thrombosis, detect and treat coronary ischemia, heart failure, and cardiac arrhythmias, start long-term antiplatelet therapy or oral anticoagulation, as well as normalizing the body temperature and blood glucose. So, also we use recombinant tissue plasminogen activator. We consider this when the patient presents within 3 hours of neurologic deficit. The CT confirmed that there is no intracranial hemorrhage. The AHA recommendation prolongation of the window to 3 to 4.5 hours for patients less than 80 years old and also who have a National Health Institute score less than 25 and with no prior history of stroke or diabetes. Recombinant tissue plasminogen use require a careful assessment by a clinician experienced in treatment of stroke because it carries a risk of 6% of intracerebral hemorrhage, usually among patients with severe strokes. So it has contraindications. First, major surgery within the previous 2 weeks. Second is previous intracranial hemorrhage. Third, systolic blood pressure more than 185 or diastolic blood pressure more than 110. The fourth is symptom of subarachnoid hemorrhage. The fifth is recent and controlled bleeding. The sixth is coagulopathy, and the seventh thrombocytopenia, and finally ENR more than 1.7. So we can use atiplas with endovascular thrombectomy in cases. In 4 recent randomized clinical trials, we find that endovascular thrombectomy in patients with proximal large vessel occlusion of the anterior cerebral circulation provided significant benefit when treatment began within 6 hours of stroke onset. Most patients received atiplaza given by IV before endovascular thrombectomy. Benefits were seen at 24 hours within 50% reduction of the National Institute of Health score, at 90 days with improvement of functional outcomes. Now we discuss transient ischemic attack. So transient ischemic attack defined as a brief episode of neurologic dysfunction caused by focal ischemia to the brain or spinal cord that does not result in acute infraction. Traditionally thought to last up to 24 hours, newer imaging make it clear. So transient ischemic attack typically lasts less than 1 to 2 hours. Longer episodes are commonly associated with acute infraction. Transient ischemic attack is a major risk factor for subsequent stroke. Management following a transient ischemic attack. So transient ischemic attack symptoms should be evaluated emergently by brain imaging, ideally with MRI. Is important to determine whether there has been an acute stroke, if one founded its location and its type. Non-invasive imaging of the carotid artery, EKG, and echocardiography are important to determine the most likely cause of ischemia. And finally, initiate treatment for secondary stroke prevention based on the results of the evaluation. So preventing of ischemic stroke, monitoring blood pressure is very important. So maintaining blood pressure less than diastolic less than 140 and systolic blood pressure less than 140 and diastolic blood pressure less than 90 for secondary stroke prevention, and for primary prevention in those with other risk factors such as diabetes. Also, it is important to start statin therapy for primary prevention in patients estimated to have a high 10-year risk of cardiovascular events based off the American Heart Association guideline. So we use high-intensity statin therapy for patients who have had transient ischemic attack or stroke believed to be atherosclerotic origin, regardless of the LDL level. Also, we follow the preventing of ischemic stroke. Several studies have confirmed a 2 to 4-fold increase in risk of stroke in individuals with diabetes mellitus. So aggressive treatment of hypertension and hyperlipidemia in diabetic population is crucial. Some research suggests that tight control of blood glucose levels in healthier adults with diabetes may reduce the risk of stroke, although the evidence for reduction of other vascular complications like retinopathy and nephropathy is more compelling. And also, it is important to support cessation of smoking, which increases the risk of stroke as much as threefold. Long-term oral anticoagulation therapy is recommended for patients with valvular and non-valvular atrial fibrillation at high risk of stroke and low risk of hemorrhagic complication. For valvular atrial fibrillation, warfarin dose to a target ENR of 2 to 3. For non-valvular atrial fibrillation, first-line option are warfarin with ENR 2 to 3 or apixaban, ondoxaban, or rivaroxaban with dabigatran or as an alternative. Consider aspirin for patients with non-valvular atrial fibrillation and low risk of stroke. If possible, initiate oral anticoagulation within 14 days of transient ischemic attack or stroke in those with atrial fibrillation. Okay, so Dr. Lojain will continue the rest of the presentation.
Oh, hello everyone. This is me, Lojain Abdelfadeel. I'm very glad to be here with you. I will complete what my colleague started. So we will move on on the prevention of ischemic stroke. So following non-cardioembolic ischemic stroke, aspirin is mainstay of antiplatelet therapy for secondary prevention, and we need to use the minimal necessary dosage. The minimal necessary dosage has not been determined. Other antiplatelet medication have not shown consistent superiority to aspirin. In two large trials, there is no benefits was found for the use of warfarin over aspirin for secondary prevention in the setting of a large vessels disease, including intracranial atherosclerotic disease. So we will move on in the management of ischemic stroke. Usually in the management of a stroke, we will focus on what the underlying cause of the ischemic stroke. For example, in the patient who having carotid stenosis, we try to treat the underlying cause, which is the carotid stenosis. And the management of the carotid stenosis, it depends on two things, which is the status of the patient, either symptomatic or not. And the second thing is the degree of the stenosis. So if the patient has the stenosis equal or more than 70% and he is symptomatic, a carotid endarterectomy should be the management of this patient. And if the patient who has recent TIA and or ischemic stroke and ipsilateral moderate carotid stenosis, we should consider carotid endarterectomy. In patients with asymptomatic carotid stenosis with a degree of stenosis more than 70%, we may consider carotid endarterectomy or endovascular treatment with carotid artery angioplasty and stenting. But this should be considered only if the risk of perioperative stroke, myocardial infarction, and death is very low, which is less than 3%. Then we're going to move to how we treat cryptogenic stroke. As I mentioned earlier, we should focus and try to treat the modifiable risk factors for a stroke. Additionally, we should start antiplatelet therapy. If the patient presented with a stroke and the underlying cause was the cardioembolic issue, we should use monitor to monitor the cardiac rhythm for atrial fibrillation, and we should start oral anticoagulant therapy if we suspect or we found there is an intermittent atrial fibrillation. In the setting of the patent foramen ovale and venous source embolism, we should consider oral anticoagulation. And if the oral anticoagulation is contraindicated in such patient, we should use inferior vena cava filter or transcatheter patent foramen ovale closure as a management plan. Then we should move to the second type of the stroke, which is a hemorrhagic stroke. The cause of a stroke here is a hemorrhage rather than thrombus or embolism. Which accounts for 15 to 20% of all the strokes. There is many subtypes of this type of stroke, which is intracranial hemorrhage, subarachnoid hemorrhage, subdural hematoma, and finally we have epidural hematoma. Usually, the patient with hemorrhagic stroke may present with a sudden onset of focal neurological deficits, and this is associated with severe headache, vomiting, high blood pressure, decreased level of consciousness, and even coma. And this type of stroke carry higher risk of mortality when we compare it with ischemic stroke, and it should be treated in the comprehensive stroke center. When patient presented with above-mentioned symptoms, we should immediately do a brain imaging to determine which type of stroke this patient have, hemorrhagic or ischemic stroke. Then we're going to move to the management of the intracerebral hemorrhage. We know that one of the major causes of intracerebral hemorrhage is high blood pressure. So one of the important steps in the management is to maintain the blood pressure of our patient with the goal that the blood pressure should be 140 for the systolic blood pressure. And if our patient have bleeding problem due to warfarin, we should immediately reverse the action of warfarin by using IV vitamin K and replace the vitamin K dependent clotting factors to bring the INR to the normal rate. And if the patient have a severe coagulation factor deficiency, we should consider factor replacement therapy or platelet as needed. In case of hemorrhagic stroke, or if we suspect that our patient have any kind of hemorrhagic stroke, we should immediately stop all anticoagulants and avoid to use or anticoagulants or antiplatelets during the acute period. So after that, after we manage our blood pressure, we set a goal of 130 millimercury for systolic pressure, less than 130 millimercury of systolic pressure, and less than 80 millimercury for diastolic pressure. And then we should put on our plan when we should use our anticoagulants. If our patient has a high risk for future ischemic cerebrovascular events, we should start our anticoagulation within 2 weeks of hemorrhagic strokes. But any other patient with no history or any risk of ischemic cerebrovascular stroke, we should avoid use of oral anticoagulants for at least 4 weeks to prevent a recurrence of hemorrhage. Then we're going to talk about the second type of hemorrhagic stroke, which is a subarachnoid hemorrhage, and this is usually occur due to vascular abnormalities like intracranial aneurysm, which constitute about 80 to 50 to 85% of cases, or other abnormalities like AV malformation. So what is the risk factor for rupture of intracranial aneurysm? This depends on the size of the aneurysm, the age of our patient. So the older patient has a higher risk than the younger one. Female gender, posterior circulation location, enlargement of aneurysm over time, or any previous history of subarachnoid hemorrhage. So any patient with an aneurysm, he has a high risk of rupture and should be referred immediately to neurosurgeon. The management of subarachnoid hemorrhage is similar to that of intracerebral hemorrhage, but we should include the surgical intervention and focuses on detection and treatment of arterial vasospasm because it's a common complication. Then we have a subdural hematoma, and this is the type of hematoma usually result from the head trauma, even a mild trauma in the elderly patient. And this is defined as a collection of blood between the dura and arachnoid matter. Sometimes may be present bilaterally, and this constitutes about 15% of cases, and some older adults suffer from chronic subdural hematoma, and it could be symptomatic. The incidence of subdural hematoma increases with age, and it's related to other risk factors such as clotting disorders, shunting procedures, seizures, and in 50% of cases, there is no history of head injury. Okay, what are the symptoms of chronic subdural hematoma? First of all, headache. Then the patient may present with cognitive impairment and may present with focal neurological deficits. Sometimes a patient may present with seizures with or after subdural hematoma. How we could treat a chronic subdural hematoma? This depends on the patient status. If the patient is symptomatic, so we should refer immediately the patient to the surgeon to remove the clot. And if our patient asymptomatic, we try to monitor him appropriately because eventually this hematoma may resolve without surgery. Okay, then let's flip to another slide, please. Okay. In summary, Cerebrovascular disease is a leading cause of disability and death among older patients. Acute stroke treatment can effectively improve outcomes in patients, especially when care is provided soon after stroke symptoms begin and in multidisciplinary stroke center. Primary and secondary stroke prevention can significantly decrease the burden of cerebrovascular disease in older population. So we will end our session by scenarios. I need your participation, please. So our first case is 79-year-old woman has palpitation and shortness of breath. There is no history of cognitive difficulty or bleeding diathesis. Last winter, she fell on ice steps. On examination, he has irregular heart rhythm, no murmur, no evidence of valvular disease. ECG showed new onset atrial fibrillation, heart rate of 78 beat per minute, and heart creat was 1.6 millimercury per deciliter. So, which one of the following is the most important to consider before ordering anticoagulation for this patient? Her age, her history of falls, her renal function, or her blood pressure? Your participation, please, in the chat.
Maybe you can bring up the question once again so people can read it and then
Okay.
try to associate.
Okay.
Mm-hmm.
So most of you choose the second answer, which is her history of falls. Why do you choose this answer? Why did you choose this answer? Anyone who chose the second one, please.
If anyone has an explanation for their answer, you can just switch on your mic and speak up.
Actually, anyone who chose her blood pressure, we didn't mention any blood pressure on this in the scenario. So can we move to the answer, please? So I believe that her renal function is the main cause that we should consider because her level of creatinine of 1.6. So many of the anticoagulants, pharmacokinetics and pharmacodynamics significantly may affect by the renal status of the patient. So when we have a patient with the abnormal renal function, we should use anticoagulants with precaution after a thorough research about which one will be the right one for our patient. So I believe her renal function is the right answer. So if that answer sound reasonable for you, everyone?
For a history of fall, it's been 1 year, so I don't think that it will affect anything.
You mean her fall?
Yeah, her history of fall, like for choice B. So, the vignette said that like she has fallen 1 year last winter. So
Anyone has an explanation? I believe so. My patient don't have any history in then don't have any information in her history that suggests that may have any problem that suggests that she had any kind of subdural hematoma, because there is no history of cognitive difficulty, bleeding diathesis, there is no any abnormalities in her brain. So if we go back to the subdural hematoma, the chronic subdural hematoma, you might see that the patient may have a headache, may have a moderate cognitive impairment, may have a focal neurological deficits. Yeah, did you get the point? So my patient don't have any kind of these symptoms.
Yeah, it's clear now. Thank you.
Okay. Then let's move to the second question. We have an 88-year-old woman has sudden onset of deafness in her right ear, accompanied by intermittent episodes of dizziness during which the room spins very quickly. Her symptoms began 2.5 hours ago. She has fallen twice since symptoms began, and she has walked into walls. Has a history of coronary artery disease, hypertension, cervical spine degenerative disc disease. Has no history of stroke, TIA, or diabetes. Her medication is aspirin, statin, and antihypertensive agents. She lives independently, uses a cane, and drives. Which one of the following would be the most appropriate first step in her management? Obtaining an audiogram, obtain laryngeologic evaluation, obtain urgent computed tomography of the brain, and prescribe meclizine. Okay. Yes. All of you agreed with the third option, and I'm totally agree with you, because our patient has sudden onset neurological deficits. In addition to her medical history is a highly significant. So yeah, first of all, we need to obtain urgent computed tomography of the brain to exclude any kind of stroke. That's very good. So let's move to the last case. We have a 90-year-old woman comes for follow-up 1 week after discharge from the hospital, where she was treated for a right 1 centimeter basal ganglia hemorrhage. She is accompanied by caregiver from the facility where she received a PT and OT. Blood pressure on arrival at the hospital was 220/1/6 mmHg. At today appointment, the caregiver reports that she tends to be sleepy and difficult to arouse in the morning, but is otherwise doing well. Her appetite is good. She has had no loss of consciousness, seizure-like activity, or headaches. There has been improvement in left-sided weakness. Her medical history include coronary artery disease, hypertension, remote myocardial infarction. She had been a heavy cigarette smoker but quit 24 years ago. Her medications in the 6 months before hospitalization, she had been progressively forgetful and may not have taken her medication as prescribed. Aspirin, 81 milligram per deciliter per day, levetiracetam, 500 milligram twice daily, amlodipine, 10 milligram per day, chlorothalidone, 25 milligram per day, metoprolol, 25 milligram twice daily. Examination showed blood pressure of 116/86 and heart rate of 60 beat per minute and regular. Which one of the following is the most appropriate next step in management? Discontinue aspirin, decrease metoprolol dosage to 25 milligram per day, decrease levetiracetam dosage to 500 milligram per day, discontinue levetiracetam. So do you believe the correct answer? We can go back to the scenario again. Okay. Regarding her vitals, now her blood pressure is 116/86 and heart rate is 60 beats per minute. And now she has been progressively forgetful. Also. Okay, why do you believe that we should reduce metoprolol? Actually, this question confusing me also. So, decrease the aspirin, discontinue aspirin. Okay. What else?
I think it's choice A, discontinue aspirin. She just had 1 week since she had hemorrhagic stroke.
Okay.
It said that they should be held until like 4 weeks or so after
Mhm.
the incident.
Okay. So for me, this question is really confusing. So if you don't mind, Dr. Nader, can you help us to solve this question?
Sure. Let's go back to the question.
Okay.
So she had a hemorrhage 1 week ago
Yes.
and accompanied by caregiver from facility. So blood pressure is high, and one of the option is beta blocker. So are you going to increase the beta blocker or decrease the beta blocker? That might be something. And then her history, she had remote MI, she had history of hypertension, coronary artery disease. So the aspirin 81, I'd go with discontinue the aspirin for some time and then restart after you do the imaging. See if the bleeding continues or stable.
Okay.
Decreasing the metoprolol, I don't think it's a good idea because she
Yes.
high blood pressure, and decreasing the dose for Keppra or discontinue Keppra might not be a good option.
Okay.
Does that include or discontinue? What the explanation for discontinue Keppra did they mention?
They didn't mention, and I didn't believe this is the correct answer.
Uh-huh.
Yeah.
Yeah, sometimes they have an explanation on the slides, sometimes they might not, but yeah.
Okay. Thank you so much, Dr. Nader, and thank you all of your audience. We come to the last slide. Thank you very much.
Thank you so much, both of you. Great
So
to-
I want to share the modifiable This is the National Health Institute stroke scale. So you can find it in this side. And it gives you the points. The higher the scale, the worse prognosis. So here, okay, so this is conclude our presentation.
Thank you for the very well made presentation. Dr. Rahma, I think if you share the link to the scale, that would be great. If anyone wants to visit the website and try it for themselves, that would be very
Yeah,
helpful.
yeah, I will do that.
I'll open the floor for any questions to both Dr. Lojain and Dr. Rahma for if anyone has any question. If not, then I think we can move on. So our second topic is evidence-based practice in medicine. This is going to be presented by Dr. Amna Elazrag and Aseel Imad. If you guys are present, just let us know.
Yes, we are.
All right.
I'm going to share my screen, and then Dr.
Mhm.
Aseel will start.
All right. So I think Dr. Nader, you can just give them the hosting rights, and then they.
They can go ahead whenever you are ready.
Okay, Dr. Amna, you can just share your screen and start.
Okay.
Mhm.
1 second. Is it clear?
We can see your screen, but yeah,
Okay.
now the presentation is on.
Okay. Aseel, are you there?
Yes, I'm here.
Okay, you can start.
Okay, hello everyone. Today we're going to present about evidence-based practice by me and other doctor, Amna Elazrag. Okay. First of all, we're going to start by the objectives of this evidence-based practice. Firstly, it is to define evidence-based practice and its characteristics. Secondly, to summarize the history of evidence-based practice. Then to apply evidence-based practice to other disciplines. And lastly, to identify sources of evidence for various subject areas. Okay, so the definition of evidence-based practice is the conscientious, explicit, and judicious use of current best evidence in making decisions. That was wrote by Sackett, Rosenberg, Gray, and Haynes, and Richardson in 1996. Another definition for it is applying or translating research findings in our daily patient care practices and clinical decision-making. A more clear definition for that is trying to make the best decision with the best evidence. So it is a process that combines well-researched interventions with the following. That is clinical experience, according to the experience of the doctor or whoever is making the decision. Professional ethics, the medical decision or any kind of decision should be according to ethics. And patient preferences, that is what patient prefer or wants according to his decision. Lastly, the culture of person or setting. It should be also according to the culture of people in that area. So evidence-based practice is synonymous or similar to other terms in use. Other terms that like evidence-based practices, evidence-based treatment, evidence-based intervention, evidence-based care, and lastly, evidence-informed intervention. It all means the same, to use evidence that is researched to make decisions. Okay, so here we're talking about the history of evidence-based practice. It has its roots in evidence-based medicine that is also referred to as evidence-based healthcare. It was created in the 1980s, and it was only then popular in the 1990s, and it's also becoming more popular nowadays, I believe. So medical textbooks were unable to keep up with the rapid changes in medicine and were frequently based on the interpretations of few people in respective fields. At the same time, the medical literature in journals was being produced in record numbers, yet was poorly organized. I think it was also because they didn't have internet and other sources, so research wasn't easily accepted and accessed like nowadays. Okay, but it's always been done this way. Health science and other fields realized many tasks and treatment were based on experience or routine rather than empirical proof. So people only do the task according to what they already know. Only few people actually research things and ideas to learn more. Accountability, numerous accrediting agencies, organizations, government and public wants to see that resources are going towards what's shown to work. And then cost effectiveness is used in England's national health system to evaluate this, and often in US healthcare or insurance. And then we have the multidisciplinary teams. Some problems are too complex for a single discipline to address. Here we have an example of, for example, if a child has speech problems, then that person might need teacher, speech therapist, and social worker team to prepare a child with speech impediment to successfully transition in mainstream classrooms. Okay, so here we're going to talk about the difference between evidence-based practice and evidence-based medicine. So evidence-based practice is a more general term. It encompasses a lot of things, factors, and sectors. So evidence-based medicine is focused on medicine, while evidence-based healthcare is focused on general healthcare. They are primarily limited to the healthcare field and focus on specific patients or populations. Evidence-based practice can be applied to many fields and is constantly being modified to best suit the subject where it is being applied. Evidence-based practice has been used in social work, education, and other human service fields. Okay, so here are the 5 steps of evidence-based practice. First, we have to define the question that needs to be answered. We have to know what we're looking for, and then to acquire the literature that will be analyzed. That is the research we're going to do, building and executing the research. Thirdly, we have to, that is critical appraisal, conducting a formal evaluation of the results. That includes evidence and patient preferences to look at it in a holistic manner, integrating the evaluated evidence into practice, and lastly, to re-evaluate the process to assess its efficacy and improve it in the future. So if it works, we can try it again, or it doesn't, we can just deny it. Here is defining the question, the first part of it. In evidence-based medicine, a question is structured and defined in a specific way, referring it as PICO question. So in order to generate the question, we have to use the PICO method. P stands for patient, population, or problem. I for intervention, that is either drug or diagnostic tests, etc. C for comparative intervention. O for outcomes, that is the desired result. This can be modified for evidence-based practice. Okay, so here we have an example of PICO. We have to understand what is the patient, intervention, comparative, and outcome. Here is a 52-year-old African-American male with type 2 diabetes. Is metformin better than insulin at regulating blood sugar? Here, our patient is 52-year-old African-American male. The intervention we're thinking about here is metformin, and we're comparing insulin with metformin. For the outcome here, the desired result is blood sugar levels. Okay, here's another example. Applied to criminal justice. Okay, so is re-entry programming more effective than participation in corrections education program in reducing recidivism among people released from prison? That is whether people do other criminal things after being released from prison. Here, our population or problem is prisoners or inmates for recidivism. Our intervention here is re-entry programming. Comparative intervention is corrections, education programs, and outcome we're searching for is decreased recidivism. Okay, here's another example applied to library settings. In a library with decreased budget, which is more effective, a self-checkout machine or checkout desk for borrowing books? Here is our population is library, decreased budget. Intervention here is self-checkout machine. We're comparing it to checkout desk. And the outcome we're looking for is cost effectiveness. Okay, here the question is when to apply evidence-based practice. Evidence-based practice may not be suitable for certain types of questions or scenarios. Here we have 3 scenarios in which it's not suitable. First is background question. The need is to define or identify some concepts rather than compare interventions. Here, if we're not comparing things or interventions, then we shouldn't use evidence-based practice. For example, here are what are effective strategies of increasing parental involvement in an elementary school. Another example of where things we can't use evidence-based practice for is factual questions. The need to identify some facts that do not necessarily come from scholarly research. For example, the question, what was the population of Florida in 1950? Here we can only get one answer, and so we shouldn't use evidence-based practice. No comparison can be made. Too few available studies. Utilizing evidence-based practice is difficult if little has been published on the research question. Is the use of herbal remedies for pain management during childbirth more effective than conventional medicine in high-income communities? So here we're not going to find a lot of data regarding that. Okay, so my colleague Amna is going to complete the rest of the presentation. Thank you so much for your time.
Okay, thank you, Aseel. My name is Amna Elazrag. I will complete the rest of the presentation. We'll start by the third part is the critical appraisal. What is critical appraisal? The definition is the process of carefully and systematically examining the research to judge whether it's valid, its validity, reliability, and it's relevant to the particular context. So a study can be critiqued by many factors. First, we have the study or the research design. So an appraisal of a study requires reasonable knowledge or level of knowledge of the types of the research design. We have broader types of research design. First, we have the experimental versus observational study. We have the quantitative versus qualitative study, and also mixed method, where we can combine the quantitative and the qualitative as well. So we should know the research design before critically appraising research. So get to know the research method of a given field to determine their study design and how or if the evidence-based practice can be utilized. So an appropriate study design will be determined by the nature of the question being answered, the research question. I mean, the hierarchies of or a level of evidence have been established in various fields to demonstrate the robustness of the research. What are the considerations in the critical appraisal? First is the hierarchy of or a level of evidence, and the hierarchies consist of varying level of research. It should be ranked by the subject area or the discipline, then by the type of the research done within the discipline, and the committees or organizations who create the evidence-based guidelines. So the evidence-based practice does not assume the innate superiority of a particular research design. No, it all should be based on the question or the need. So we don't say just because that is a higher type of evidence, so it should be considered as a higher research. We should also always go back to the research question and decide whether that specific study design is appropriate or not. Okay, this is an example of hierarchies. This is the pyramid of evidence in medicine by Sackett, Rosberg, Gray, and Haynes and Richard, 1996. So at the bottom, we have the in vitro research, and then the animal research, and then editorial opinions and ideas. Superior to them are the case report, followed by case series. Then we have, I think there should be case cross-sectional studies before the case control studies. And then on top of it is the cohort. Finally, the randomized control trial. And at the top of the pyramid, systematic review and meta-analysis. This is another example of hierarchies. This is the hierarchy of evidence for intervention question in nurse male length model. So by Millian and overhaul 2019. So the first level, or we should start from the bottom. Level 7 is the expert opinion. Level 6 is the single qualitative or descriptive studies, evidence implementation and quality improvement projects. Level 5 is the systematic review, meta-synthesis of qualitative studies. Level 4, cohort or case control study. Level 3 is the experimental studies for a non-randomized control trial. Then the randomized control trial, the single randomized control trial. And level 1 is the systematic review or meta-analysis of a randomized control trial. Okay, this is another example of hierarchy. This is the hierarchy of evidence in research methods, social work. This is by Royce, 2020. So at the bottom, we have the qualitative studies, then the surveys, followed by experimental group studies. Then we have case control and cohort studies. Again, followed by the quasi-experimental study, which is the randomized control trial. Above them, there is the randomized control trial, and again, on the top of the pyramid is the meta-analysis and systematic. Okay. Okay, how to identify the biases? So a part of a critical appraisal is to identify if there was potential sources of biases in order to evaluate the validity of a study. So a common type of biases, among many, we have a conflict of interest bias from the researcher, the wrong sample size bias, which is, could be easily avoided by appropriate calculation, positive result bias, when you're eager to find a positive result or only present the positive result, the correlation bias, the missing clinical data bias, there is any missing data, the discipline bias, and the publication data bias, the publication data bias, sorry. Okay. Again, we have, again, in the critical appraisal, they form a format to just for the part of the research. Sections of the research could be created. So it's the abbreviation is IMRAD, which stands for Introduction, Method, Result, Analysis, and finally the discussion, which is the main part of the research. So for the convenience of the reader, scholarly articles in many disciplines evolve to follow the IMRAD format or something like it. So we start by the introduction, which would contain the background, the rationale, and the purpose of the study, followed by the methodology, which include the study design, the measurement instrument, and the rationale for their use. Then we have the result, where we describe the result without repeating the methodology. Analysis, some articles include this, which is the statistical analysis. And finally, there is the discussion. In the discussion, we should mention the principle, the relationship, and the generalization drawn from the study, the strength and the weakness of the study design, also included in the discussion, and how the results support or refute the previous one, the comparison in the previous studies, and the theoretical implication, finally, the conclusion. The shortcoming or argument against the evidence-based practice, first is the cookbook approach, which is simplifies the practice and stifles the novel approaches, and the time between doing the research and getting published. So the empirical research is time consuming and can take up to 2 years before it's published. So they can argue that the result therefore is outdated. The lack of evidence-based practice cannot adequately address the concepts that are not widely studied or published yet, and the overlook on the human experiences. Its outcome-based focus may simplify the complexities within people and their behavior. Okay. Sources of evidence. Generally, we have indexes and databases. disciplines specified, the well-designed and empirical article, the systematic review, and meta-analysis, and finally the thesis. We have also the journals, so journals or articles with an evidence-based focus, for specific journals with specific topics, and we have the gray literature, which is the professional association of guidelines. They have guidelines, standards, or protocols. We have the government agencies, and to use these based on professor or assignment preferences. So all of these can be a source of evidence. Yeah. Source of evidence in health sciences. We have the Cochrane Library. You heard about it. So the Cochrane Library is comprised of 6 different databases that provide information supporting the top 3 level of a hierarchy of evidence, which are the randomized controlled trial, the systematic review, and the meta-analysis. So systematic review and meta-analysis, we have the Cochrane database of systematic review. For randomized controlled trial, we have the Cochrane central register of the controlled trial. And finally, we have something that called Cochrane clinical answer, which also provide you with clinical answer based on the top 3 or top 3 evidence or type of research regarding the study design. Again, for sources of evidence, you can use the limiters and other features available for filter of the result. We have the Senha limiters, clinical queries, therapies, prognosis, review, qualitative, and etiology, and the randomized control. In PubMed, we have the clinical queries. Again, you can find therapy, diagnosis, etiology, prognosis, systematic review, and the clinical prediction guides. Okay. Sources of evidence regarding social work. We have something called the Campbell collaboration, which is systematic review in the field of education, the criminal justice, and social welfare, and they are freely available online on the website. They include plain language summaries. Social Work Policy Institute as well, and we have the SHA, which is the Evidence-Based Practices for Research Center. It's evidence-based practice for substance abuse and treatment, mental health disorder, prevention and treatment, and adult evidence-based practice. We have also the Journal of Evidence-Based Social Work. Okay, sources of evidence for criminal justice. We have the National Institute of Corrections, evidence-based decision making. We have the Crime Solution, the government, which is also a website. We have the National Criminal Justice Reference Services, and it has all the CGRS abstract databases on the website, and the Criminal Justice Policy. Sources of evidence education. The best evidence encyclopedia by Johns Hopkins University. What work? Clearing House Institute of Education Style. Culturally responsive teaching, education Northwest. Okay. For more information, you can go through these references. Thank you, everyone, for listening. If anyone has any questions, you can share it with them.
Thank you for the presentation. If anyone has any questions, they can go ahead. Yes, go ahead.
First of all, thank you so much for the presenters for the comprehensive presentation in regard to this important topic, which is evidence-based medicine. I just want to add that evidence-based medicine is quite important topic for us as physicians because the idea behind evidence-based medicine is that, as mentioned in the presentation, that we want to provide for our patient the best medical practice. And it has been found that in the literature that there is a gap, usually gap between the best practice and a latest standard of care for patients and how the practice is being done. Usually there are so many researches showing that the practice of evidence-based medicine is suboptimal in so many societies. in the Middle East, even in Western societies. So there is a gap in the practice, and this gap might be due to deficient knowledge or suboptimal knowledge about the importance of evidence-based medicine, the methodologies of critical appraising of literature, among others. I found the presentation really interesting. The presenters spoke about most of the important things about evidence-based medicine. I just want to add that there is less, some evidence points that there is less insurance claims when we practice evidence-based medicine, and there are higher staff satisfaction when there is evidence-based medicine implemented. And that's it. Thank you so much for the interesting presentation.
Thank you so much, Dr. Rahma.
Thank you so much.
Thank you, Dr. Wafa, for the great addition. I'm opening the floor for Dr. Nader if you have anything to add.
No, I think both did great job. So excellent presentation. It's an important topic, and I think you will find it useful when you use it, hopefully when you start your practice here in the US or maybe abroad. Thank you.
Thank you. We'll also have, we'll upload like the presentation to the application. So if anyone wants it for future reference, it'll be there in the application, inshallah. We'll move on with our agenda. Next topic is the multi-element care transition model. This is going to be done by Dr. Rana Ganawi. Dr. Rana, if you're present.
Yes, hello, I'm ready.
All right. You'll have the host rights in a second, and you can just go right ahead.
Okay.
Thank you.
You can share your screen, Dr. Rana.
Okay. Can you see my presentation now? Hello, can you see my presentation?
No. Did you try sharing your screen? Yep.
Yes.
Now it's
yes.
there. You can just open the presentation and go ahead.
You see it now?
Yeah, now it's visible.
Okay. Hello, everybody. It's my pleasure and honor to present as such great topic in the telegeriatric research program. So we have to start transitional care. This is an introduction. Transitional care is a broad term that encompasses a variety of intermediate care services, including subacute, skilled, and rehabilitative care services. Transitional are bridges the gap between the hospital and home for patients with complex or multiple problems. So we have to know about what is the meaning of care transitions. The term care transitions refer to the movement patients make between healthcare practitioners and setting as their conditions and care needs change during the course of a chronic or acute illness. The transitional care or care transition is defined as a set of actions designed to ensure the coordination and continuity of the healthcare as patients transfer between different locations or different levels of care within the same location. So it is a representative location include but are not limited to hospitals, subacute and post-acute nursing facilities, the patient's home, primary and specialty care offices, and long-term care facilities, as said by the American Geriatric Society. So it occurs at multiple levels within settings, as in primary care, specialty care, or in intensive care unit world, or between settings such as hospital or in subacute facilities, ambulatory clinic senior center, or in hospital home, or across health states, or in curative care, palliative care, or hospice care, or in personal residence assisted living. Now we have to know about the needs of transitional care in intensive care unit. Critically ill patients in the intensive care unit often experience a lot of changes as they move through different levels of care. Ineffective transitions can lead to poor outcomes, such as wrong treatments, delay in diagnosis, severe adverse events, patients' complaints, increase healthcare cost, and increase the length of stay. There is problems that illustrate inadequacies of care transitions, such as medication errors, increased healthcare utilization, inefficient or duplicative care, inadequate patients or caregiver preparation, inadequate follow-up care, dissatisfaction, and litigation or bad publicity. Then we have to know about the elements of the transitions of care, which is communication, changes in plans of care, medication reconciliation, follow-up tests and services, education of the patients and family, transfer of all information when sites of care changes, involvement of teams during hospitalization, discharge, and follow-up, etc. So we have the transitional care model. Firstly, we have to screen and engaging elderly and caregiver, managing symptom, education and collaboration, assuring continuity, coordinating care and maintaining a relationship. Also, we have the 4 pillars key elements, which is medication self-management. Patient is knowledgeable about medications. Patient has medication management system. Dynamic patient-centered record, which is a patient understand and utilize personal health record to facilitation, communication, and ensure continuity of care plan across providers and setting. Also, patient or informal caregiver managing the personal health record. Then we have the 3rd one, which is the follow-up. Patient schedules and complete follow-up visit with the primary care physician or specialist. Patient is empowered to be an active participant in these interactions. And the 4th one is the red flags. The patients have to be knowledgeable about the indications of their condition is worsening and how to respond. Uses of care transition intervention. Patients who receive this program were significantly less likely to be readmitted and more likely to achieve self-identified personal goals around symptom management and functional recovery. Then we will go to the barriers to care coordination. We have system level barrier, practitioner level barrier, and patient level barrier. So there is a barrier at each level of the targeted categories. We have the practitioner level barriers. Practitioners often have not practiced in setting where they transfer patients. So they are not adapted to transfer patients. Sending practitioners may not communicate critical information to receiving practitioners. Practitioners may not know the patients and his or her preference for care, practitioners have no accountability. Then we have the patient levels barrier. Patients assume that someone is in charge of coordinating care. Patients and caregiver are often the only common thread waving between care sites, yet they navigate the system with few tools or training to manage in this role. Then we have the key components of a successful transition. We have to focus on patients and caregiver understanding, helping patients manage health issues and prevent decline, medication reconciliation and management, and transitional care, not ongoing case management. Then we have to know about the role of the transitional care nurse. The transitional care nurse role is very different from a traditional nursing position. It incorporates the skill of a nurse, care manager, and patient advocate and knowledgeable of evidence-based care, managing complexity, palliative care, active management of family caregivers, interdisciplinary team care, theories and strategies for individualized care and behavioral changes, quality improvement and organization, delivery and financing of services across an episode of acute care. So healthcare transitions ensure safe and efficient movement of patients between different sectors of care within the healthcare system. Transition as a concept is central to the nursing discipline as a whole. Nurses often are the primary health professional involved in the encounter with the patient and their families that relate to the transitional period of instability. So, in a nutshell, the transitional care continuity, there is a communication between the hospital and the rehabilitation center, or the hospital and the skilled nursing facility. And in turn, there is a communication between the rehabilitation center and the home, and the skilled nursing facility and home too. In a conclusion, this is the same picture, but in another way. So there must be a communication between the hospital and the caregiver and the patient. There must be a skilled nursing facility and connection between the skilled nursing facility and the caregiver and the patient, the hospital, the hospice care too, and the rehabilitative facility and home. So thanks for your attention and listening, and I have finished now.
Thank you for the great presentation. I'll open the floor for any questions for Dr. Rana. If anyone has any question, you can ask. If not, then I guess we can just go ahead and conclude our agenda for today. We just have the projects updates. If anyone has any update to share with us today, and Dr. Nader, you can go right ahead. Dr. Nader, if there's any closing statement you want to share with us today?
Yes. So thank you so much for great presentation as well. So if there's no more questions, I will share with you some basic steps. And then before that, I want to share good news. We have Dr. Namarik Ahmed and her team. They submitted an abstract to the conference, the ADEA, and they got accepted. So they will be presenting in that conference. So congratulations to Dr. Namark and her team. So we have the dental group, and they worked on a project. So great job. Thank you. Oh, Dr. Haifa, please go ahead. Any comments from Dr. Haifa or anyone else? Or just...
Just sorry about that.
No,
Yeah,
no, that's
and thank you, Dr. Nader, for your time, and thank you for the great presentation. Just about the template, I just emailed you regarding the template for the abstract that I have to submit it, like that for the poster.
Sure. So if I uploaded some of the data or the labs, let me just...
And I have a question, Dr. Nader. I would like to, for the abstract that for the primary abstract that I submitted, that I didn't include any graphs or any charts. Is it okay if I just for the chart, if I just take information from one study, or I have to the chart that I want to create it should be include all the studies that I have worked on?
So basically, when you submitted the abstract, it's already only text format. So they will accept the idea and the conclusion from your work. So the way when you put your poster or design your poster, it's how you want to explain yourself and your findings and how you did the research and what's the results in a way that excuse me, can make it simple for the viewer or anyone comes by your poster. Usually they spend 1 or 2 minutes looking at the poster. So the more concise you make your idea or your presentation of your graphs, the better for the audience. So there is no limitation of how many graphs. There is no limitation of if you want to put tables. It's just the way you want to present your project in a concise manner. That's informative for the user or the attending. So if you go to the app, you can see my screen, right? If you go to files and you search template, so we have different types of templates here. We used some of them in some of the conferences. So you can, these are made from other websites, so I just added them. For example, this one we used in Alzheimer Association conference. So you'll have the background and everything else, and you can add pictures, you can add graphs, tables, whichever way you think you can make your idea informative in a concise manner, if that makes sense. So you can use any of these files and you can download it. It's more or less, most of them are PowerPoint. You can download them, modify them according to your needs, if that makes sense. Dr. Haifa.
Yeah. So I thought I still have the thank you, Dr. Nader. Thank you very much. I thought the mic is still open. Sorry about this.
No.
Yeah. They also require us to upload also an e-poster with audio. So I mean,
so the one I showed you is one of the poster that we did e-poster.
I see.
At the poster, sometimes they can tell you it's only one slide with video. so you don't have to move around. Sometimes they limit to 3 or 5 slides, so you can create the same poster in slide format. But you can do video. You can do it on your phone.
I see.
Then you can save the video. You can upload it to Canva. This is what we did in the past. So you upload the picture of the conference or the poster
Yeah.
background, and then you put an icon on the side, either right side, left side, and then you can, I think this is the one. So the presenter was on this side. So the video was talking about wherever, and then you can.
Okay. I see. Thank you very much, Dr. Randa. I really appreciate it. Jazakallah khairan. Thank you.
Wait a second. So one more topic I wanted to share with you. I sent some ideas, or some of the teams started working on some of systematic review, and we know we have new fellows. So if you go to this website, 2 of them, they will show you how to start up the process of doing a research project. There is a tool, it's called Lojain Systematic Review. It's free, and it's useful for either if you are an expert or if you are a new fellow, for example. This is, I think, helpful for some of you. And we have this article. It has the steps listed as far as how you start the process of systematic review. So you have an idea, and then you want to plan how you take the steps. So the first step, you want to identify your research question and write it in a manner that capture your idea. And then you go to the next step and the next step. It's very useful. And one of the chart that mostly used for systematic review is Prisma. It has 2009 and 2020, I think, or 2018 version. But the basic of the idea is these 4 steps, and then you put your findings or your results as you do the research, and you find some articles and studies. So if you go over this article, it will explain step by step. But the tool is Lojain tool. There is a few videos showing you how to go over the steps in that article. So how you find the studies, how you upload the references, how you collaborate with other fellows to review these studies, to include, to exclude some of the studies, and then you finalize your findings, combine every summary from these studies, and then you will come up with your conclusion, answering the question. Or maybe it will show you an area where you want to investigate more. So it will open the door for a new question. So you started with one question, you collected the data, you did the conclusion, but you answered part of the question, but it opened another question for you, something like that. And some of the fellows, senior fellows, did use these tools, and they presented in conferences. So if you go to the website where we published our some of the posters, so I'm going to show you here. So if you go to this website, TGRF publications.glide.page, you go to the abstract or conferences, you will find some of the posters presented by some of our fellows here in some of these conferences. Some of them are used systematic review. Thank you so much. Any questions?
Dr. Nader, thanks for the great effort you made for us. And I'm interested in doing a case report. I have a case with the cutaneous leishmaniasis with the spore trichoid pattern, but actually I don't have enough experience for that. It's my first time to publish things. So I want to the seniors follows to join me if they are interested.
Sure. So yeah, in the past, this what also fellows did. So one can bring a case similar to your case, for example, and then you collaborate with either your team or seniors and create the team for that case. So the question will be what conference you want to present your case at, and there are a few conferences, and it depends on what your criteria or what you want to present it. For example, is dermatology,
in Dubai Derma, yes, in Dubai Derma, which will be on April.
Okay, so and where you located? Where do you live?
United Arab Emirates.
So you are there. So you can
Yes.
ask some of the fellows who are interested in this case. They can join you, and then you will be the project leader, and then you can assign the task as far as who will submit the case. After you agree on the case and make the abstract, you submit it. And then if they accept it, then you assign someone to do the poster, and someone will be the actual presenter. If there are more than one, that's good. But these are the main roles of the team, for example.
Okay. Thank you, Doctor.
You're welcome.
I think you can also go to the website of the conference. They'll have criterias of what they want in the posters or what they want in the what their criteria is. So if you get to know these criteria early on, you can have your posters up to par with these criteria. So your chances of being accepted will be higher. So I think you can do that. You still have time until April, so that's quite good.
Okay, Doctor, I will do, inshallah. Thank you.
Excellent. Wishing you all the best.
Okay, I think that's another for today. It was highly informative. I thank everyone who presented today, and I thank everyone who attended the meeting. Hope to meet you soon, inshallah. That's it. Any closings, Dr. Nader?
I'd like to thank you, Dr. Omar, and every presenters from today. Thank you so much. And all those who attended today, thank you for joining us. And those who will watch the recording in the future, thank you in advance. So if you have questions, please let me know. You can communicate with your seniors. If you want to reach me, you can email me, you can text or call me. I'd be happy to assist. I wish you all the best and good luck. Thank you. Assalamu alaikum.
Thank you very much. Alaikum assalam.